Hi everyone, this is Miss Baker and I'm going to be discussing elimination with you. In this video we will just be discussing chapter 46, urinary elimination, and then there will be a separate video for chapter 47. This material will also be covered in class on Monday. Concept that applies to this module is functional ability. And these are the Nursing Skills Online 4.0 assignments that you had for your pre-class prep. We won't spend much time here in our A&P review, but just know that the kidneys lie on either side of the vertebral column, behind the peritoneum and against the deep muscles of the back. The nephron is the functional unit of the kidney, and it's composed of the glomerulus, Bowman's capsule, proximal convoluted tubule, loop of Henle, distal tubule, and collecting duct. The glomerulus filters 125 milliliters of filtrate per minute. Only about 1% is excreted as urine. If you notice that there is protein in the urine or blood in the urine, then that could be a signal that the glomerulus is not performing correctly and there may be some type of injury. Our kidneys are important to maintain fluid and electrolyte balance. Our normal urine output is 1 to 2 liters per day. If our patient is experiencing less than 30 milliliters an hour, then we need to be calling our healthcare provider. There's something going on, and the kidneys are important to help regulate potassium and sodium levels. So you need to know the correct levels, the normal levels, of potassium and sodium. 20 to 25% of cardiac output circulates each minute through the kidneys. Here's a picture of a nephron. So as discussed, the functions of the kidneys are to remove waste products, regulate fluid and electrolyte balance, and they are also important in producing erythropoietin. Erythropoietin functions with the bone marrow to stimulate red blood cell production and maturation and prolongs the life of the mature red blood cells. So patient with chronic kidney conditions can't produce sufficient quantities of this hormone and are prone to anemia. It's also important in renin secretion. The kidneys play a major role in blood pressure control via the renin-angiotensin system. So the kidneys affect our blood pressure regulation. The kidneys also affect calcium and phosphate regulation by producing a substance that converts vitamin D into its active form. And patients with chronic alterations in kidney function do not make sufficient amounts of the active vitamin D. They are prone to develop renal bone disease resulting from the demineralization of the bone caused by impaired calcium absorption. The kidneys, of course, are also important to excrete bacterial toxins, water-soluble drugs, and drug metabolites, and to also maintain acid-base balance. Here's a diagram of how the renin-angiotensin system. Don't spend too much time here right now. Just know that the kidneys and hypertension are connected. Here is a great just memory picture to discuss hyperkalemia. Muscle twitches, cramps, paresthesia, that tingling sensation, irritability and anxiety, decreased blood pressure, EKG changes, dysrhythmias, abdominal cramping, and diarrhea. That's what we're going to see in our patient with hyperkalemia. And then for potassium deficit, if you can remember a sick walt. This patient's going to have alkalosis, shallow respirations, irritability, confusion, drowsiness, weakness, fatigue. arrhythmias, may have an irregular rate, and tachycardia, lethargy, thready pulse, and decreased intestinal motility, nausea, vomiting. And here we discuss the ureters, bladder, urethra. We will note, and we'll learn about this in further topics, but women do have a shorter urethra than men, which can make them more prone to different problems. So what factors influence urination? There is a great box, 46.1, that discusses this. Just think about that. There are all kinds of different things. It could be psychological factors such as anxiety and stress, your fluid intake. Are you drinking enough water? Are you not drinking enough? Medications, diuretics increase urinary output, and some drugs can even change the color of urine, so we want to educate our patients about that. Of course, you're going to have different urinary habits with a 3-year-old than you are going to have with a 16-year-old once you get into pediatrics. So just know that there are different factors that influence urination, and study those in box 46.1. Alterations in urinary elimination. There are different processes that we will talk about here. One of those being urinary retention, and UTIs, incontinence, urinary diversion, and then we also need to focus on infection control. So urinary retention is the inability to partially or completely empty the bladder. This can be caused by urethral obstruction, surgical or childbirth trauma, alterations in motor and sensory innervation of the bladder, side effects of the meds, and anxiety. So in this situation, the bladder is unable to respond to the micturition reflex. So it's just not responding to go to the restroom. So you can also have retention with some overflow, where the patient thinks that the patient may think that they are voiding correctly when really they're voiding small amounts of urine 2 to 3 times an hour with no real relief. And this happens as urinary retention progresses. So our bladders can hold as much as 2,000 to 3,000 milliliters of urine, but we do not want them to get to that point, because if there is an overload of urine, then that bladder could rupture. So how would we assess this patient? We would assess their bladder distension. So we would palpate, see if the patient's experiencing any tenderness when you're palpating their bladder. We would check for post-residual void, and this would involve getting the bladder scanner. And this is what most bladder scanners look like, and we will discuss how to use these in class. And they are usually hard to find. At least in my experience where I have worked, they have been very hard to find. And when you go and borrow one on the floor, then they are watching you and making sure that you know that you need to return it if it's not from your floor. So make sure if you borrow one that you return it to where it's supposed to go. Okay, moving on to urinary tract infections. These are the 4th most common healthcare associated infections. The most common cause of these infections is E. coli. It's the most common causative pathogen. It's responsible for 75 to 95% of uncomplicated infections. So UTIs are usually caused by the E. coli, and if it gets really bad, and if it's ignored or not treated well, then it can lead to the spread of organisms in the kidneys, and possibly to bacteremia, which is urosepsis or bacteria in the bloodstream. Women are at more of an increased risk of this because they do have a shorter urethra that's in close proximity to the anus. And a lot of times these patients are experiencing dysuria. They're in pain as the urine passes through inflamed tissues. And then there are different types of urinary tract infections depending on the location, or they're characterized by location, I should say. So upper urinary tract infection is going to be a kidney infection or pyelonephritis, and then a lower urinary tract infection is going to be in the bladder or the urethra. Here's a good picture to help you remember some of the manifestations of UTIs. Cystitis, that bladder infection, they're going to have more of the frequency, urgency, suprapubic pain, dysuria, hematuria, confusion. Pyelonephritis is going to include the flank pain and the increase of fever. Those are the things that are distinctive about the pyelonephritis. They also experience dysuria, and they are going to have pain and the signs and symptoms as cystitis. So with these patients, we want to provide them symptomatic relief. We want to teach them about how to prevent UTIs. We want to teach these patients to void after intercourse. We want to teach the women to wipe from front to back after they use the restroom. And this teaching even starts when a mother has a baby girl. I worked in the nursery for a while now, and that's something that, especially if they don't have any girls already, just really teaching them when they're changing diapers to wipe from front to back. So that's important. You want to teach them not to use any scented products, perfumes, and to empty their bladder regularly. When you start working as a nurse, you may have to remind yourself, I've got to take restroom breaks to make sure that you are emptying your bladder regularly. We also want to encourage these patients to have adequate fluid intake so they can flush out those toxins. And the other things we have already discussed. All right, urinary incontinence is the involuntary leakage of urine that is sufficient enough to be a problem. So this can be caused by different things, and there are different types. There is a table in your book on page 1153, table 46.1, that discusses the different types of urinary incontinence. So transient is going to be caused by medical conditions. It can be treatable or reversible. An example would be if someone is on a diuretic medication that is increasing their amount of urine, or if they have inflammation from a UTI, or even if they have delirium from acute confusion, that can cause this type of incontinence. Functional is going to be the loss of urine caused by factors outside the urinary tract that interfere with the ability to respond in a socially appropriate way. For example, if you have a patient who is immobile and the poor thing has been hitting the call light, but the nurse has multiple patients, or she's stuck in a room and no one is able to get in there to help this patient, then they may have some kind of functional incontinence. Other things that can cause this are altered mobility, cognitive impairments, and just environmental barriers. Overflow incontinence is going to be characterized by an overdistended bladder related to bladder outlet obstruction or weak bladder contractions. And this is going to be the patient that is experiencing frequency or nocturia, and we can help this patient by teaching them about timed avoiding or double avoiding, and we'll talk about that later on. Stress incontinence, the involuntary leakage of urine during increased abdominal pressure in the absence of bladder muscle contraction. So this is when you're thinking of your patients who have just given birth. These patients may have a small loss of urine with coughing, laughing, or exercise. And this patient, we're probably going to be teaching them about Kegel exercises. Reflex incontinence, the bladder usually holds as much as 600 milliliters of urine or so, and this person is going to sense the desire to avoid at 150 to 200 milliliters in adults and 50 to 100 milliliters in a child. Some patients will require a urinary diversion. So these patients have had something happen to them, whether it's trauma or bladder cancer, or maybe a radiation injury to the bladder, or maybe they had chronic cystitis that was just made them where they had to get to the point where they had a urinary diversion. And there are different types of these. There are continent and incontinent diversions. So some patients may have a urinary stoma to divert the flow of urine from the kidneys to an external source. And these types are going to be considered something that the patient may need some body image support and some education on, definitely education. So there's two types of continent urinary diversions. The continent urinary reservoir, the continent urinary reservoir, this is the picture on the right. They use part of the distal part of the ileum and proximal part of the colon to create a pouch. And this person will have to catheterize the pouch 4 to 6 times a day. And there's another option that they can do called the orthotopic neobladder that uses an ileal pouch to replace the bladder. And this patient can void through the urethra using the Valsalva technique. Then there are two types of incontinent. The uterostomy, the ureters are connected to a closed-off part of the intestinal ileum. This patient will have a stoma and have a pouch. So you can see this patient on the left has an ileal loop, and you can see these on page 1154. And the patient with the ureterostomy, that's also called that ileal conduit, and this patient will have a continual flow. And then the other type of incontinent diversion is the nephrostomy, and this patient will have tubes inserted into the renal pelvis. If they have one kidney, then they may just have one of these, but they will also have pouches that can often be strapped onto their legs. So when you are assessing your patient and you get to their urinary patterns, you want to gather nursing history for their patterns and their symptoms and their factors that affect urination. You want to perform your physical assessment of the patient's body systems that may be affected by urinary change. If you have a patient who has a ureterostomy, then it's going to be important to note that in your assessment, and you're going to know how to care for that patient. If you have a patient who is incontinent, then you will need to know that you need to check them frequently to change them for comfort and just to keep them clean, prevent ulcers. We want to care for these patients well. The nursing process provides a clinical decision-making approach by which you can develop and implement an individualized plan of care. And that's what we want to know about our patients, is what individualized needs do they need. You want your care to be patient-centered, and you want to know how to help them in this area at every shift that you come in. So you're going to assess the characteristics of their urine. You're going to assess the patient's perception of urinary problems as it affects their self-concept and sexuality. If it's someone who's had an accident that used to be fully continent is now experiencing incontinence for the first time, you want to be sensitive to that and make sure that you're providing the care that they need. If you have someone that is learning how to take care of a new ostomy, then you want to assess that as well. And also to be an advocate for your patient, and so that you know how to keep your patient safe, you want to perform clinical judgments that require you to collect necessary information. So you want to analyze the data and make decisions from that data regarding the patient care. So you're going to want to gather relevant laboratory and diagnostic test data. Common symptoms of urinary alterations. You can find all this information on page 1159 in table 46.2. You will need to make sure that you review these and that you know what each of these, the description of each of these and the causes of these. And that is all on table 46.2 on page 1159. So back to that assessment, we want to look at this patient's history. We want to know what influences their urination. So that includes a review of their elimination patterns, symptoms of alterations, and other factors. Factors that affect urinary alteration include environmental factors, medication history, psychological factors, muscle tone, fluid balance, current surgical or diagnostic procedures, and the presence of disease. Older patients often experience poor muscle tone, which leads to an inability of the bladder to fully empty. Residual urine greatly increases the risk of infection. In following Maslow's hierarchy of needs, physical health risks should be addressed before emotional and cognitive risks such as anxiety and self-esteem. Decreased mobility can lead to a self-care deficit. The nurse's priority concern for this diagnosis would be infection, because the elderly person must rely on others for basic hygiene. So we want to keep our patients comfortable and clean, and also reduce the risk of infection. So when you are assessing your patient, you want to focus on their kidneys, bladder, external genitalia, and the skin around their perineum. You also are going to need to assess their I&O. If your patient is urinating less than 30 milliliters per hour for more than 2 hours or greater than 2,000 milliliters per day, then we want to discuss that with the healthcare provider. So if it's been 2 hours and your patient is not giving you the correct amount of urine, we're going to be on the phone or finding the healthcare provider and giving them this information. Characteristics of urine to pay attention to are the color, clarity, and the odor of urine. The color should be pale straw to amber, and urine is going to be more concentrated in the morning. Medications can also change color of the urine, And that's something that we want to educate the patients about if they are going to be on these medications so that they don't get scared. I know I would be scared. And also foods such as beets, rhubarb, and blackberries can change the color of the urine. Dark amber urine is the result of bilirubin from liver disease. If urine is stagnant, it's going to have a strong ammonia odor. A sweet or fruity odor is seen with diabetes mellitus or starvation. So those are things that we want to be looking out for. Is it cloudy? How does it smell? What color is it? Urine testing on table 46.4. You can see the different types of urine testing. Table 46.3, you can see the different types of specimens that you collect, and then 46.4 is going to discuss what information that you can see in a routine urinalysis. You can see the pH, if there's any protein, if there's any glucose, ketones, the specific gravity, white blood cells, red blood cells, bacteria, cast, or crystals. And we're going to be discussing how to obtain a urine specimen. We'll also talk about that in some lab time, hopefully. So routine urinalysis, this is going to be a clean specimen. It can be collected during normal voiding or from an indwelling catheter or urinary diversion collection bag. But we do not want to collect this from an indwelling catheter drainage bag because that urine has been sitting there, it's not freshly voided, and it may give us false results. So you want to make sure that your patient is clean if it's during normal voiding, and then there are special ports that we can use to get it from the catheter that we'll talk about in the lab. Clean, voided, or midstream, that's going to be a way to collect a culture in sensitivity. You always want to use a sterile specimen cup, and it can be collected by the patient. You just want to tell them to start urinating, then collect the specimen after their stream has started during that midstream. And next, the sterile specimen for culture and sensitivity. So if this patient has an indwelling catheter, we're going to collect the specimen by using sterile aseptic technique through a sampling port. You want to keep everything sterile because this is going to determine the presence of bacteria and which antibiotic that bacteria are sensitive to. Then you also may be collecting timed urine specimens. These are going to be tested either at a specific time of day or urine collected over a specific time period, like 12 or 24-hour collections. And usually these patients will have a sign on their door that lets you know that they are doing a 24-hour collection so that anyone that goes in to take care of them, whether it's a nurse or a UAP, then they're going to know that this person's urine needs to be collected. So with urinary elimination, we want to provide education to these patients. We want to provide the support that they may need or their caregivers may need. And that goes for every situation that we talked about today. We want to provide them great support and education so that when they go out of the hospital or out of the clinic that they know how to care for themselves. And that's part of patient-centered care. We want to promote normal urination, and we want to make this patient-specific. Some patients will need privacy. I know that it's a lot easier to give someone a sample if you've ever had to have a urinalysis or be drug tested for a job. It's a lot easier when someone's not just standing there tapping their foot. So privacy could help. You want to help maybe put them in the normal position for voiding if it's someone who's been bedridden. And the sound of running water can also help. You want to maintain their elimination habits that they may have already had. And you want to help promote adequate fluid intake. We should be drinking at least 30 milliliters per kilogram. We want to help our patients by promoting complete bladder of the emptying. We want to promote complete bladder emptying. Ways that we can do that include stroking the inner aspect of the thigh. We can pour warm water over the client's perineum, especially in the labor and delivery setting. So if we were to do that and we were measuring their output, then we would want to make sure that we know how much water we're using by using a marked bottle that shows how much is in the bottle that you're using to pour warm water. With double voiding, we were going to encourage the patient to void again even after they have voided when they think they're finished, just to make sure that they are clearing out their bladder. Scheduled toileting and also Creed's method. So some common urinary medications that you may see. The ditropan is an anticholinergic drug, and it's a urinary tract antispasmodic. So this medication is going to be used for overactive bladder, and it's used with urge incontinence. So it's going to decrease bladder contractions. And then the opposite of that, the cholinergic drugs are used for urinary retention, and they help the bladder to contract. So this is going to be that urocholine. A patient may be taking an alpha-1 adrenergic blocker. An example of this one is Flomax. It keeps the flow to the max. And this patient may be someone that has an enlarged prostate, and this medication will relax the prostate to help the urethra to not be as constricted. Urinary analgesics, such as pyridium. So this is used for pain control, especially with a UTI. It can be described as like Tylenol for the bladder. Urine may be orange using this medicine, so we want to educate our patient, because I know I would be scared if I saw that. So please be kind to your patient and educate them that this could be a side effect. And then lastly, epoetin. It stimulates bone marrow to produce red blood cells, and this may be given to patients who have chronic kidney disease to treat anemia. Examples of these medicines are Epigen and Procrit. All right, urinary catheters. You'll learn how to insert urinary catheters in U113, but for 112, you need to know the types of catheters, how to provide catheter care, and how to prevent CAUTIs. So CAUTIs are catheter-associated urinary tract infections, and they are a major focus of hospitals. And ways to prevent these are, you want to maintain a closed system. Figure 4614 in your book shows all the potential sites of infection. You never want to hang the catheter bag on a bed rail, and you want to keep drainage below the client's waist. You want to provide hygiene, and some facilities will have certain requirements for the timing of that hygiene. It may be once a shift, it may be every 8 hours, and included in that is catheter care. A lot of places want you to use mild soap. You could even use dial soap to clean around the catheter and to clean the perineum. And you want to ensure the patency of the system. There's a box in your book, 4610, all about preventing CAUTI, because that is important and it is something that you need to know. Some alternatives to urethral catheterization, and this would be a more extreme alternative, would be the suprapubic catheter, and that's a placement of a catheter through the abdominal wall above the symphysis pubis and into the urinary bladder. You can see a picture of that here. You can also use a condom catheter. It depends on the patient, but sometimes these are hard to keep secure. But on box 4612, you can see that there are 3 different methods of securing the catheter. You never want to use standard adhesive tape. Some of the condom catheters are self-adhesive. Some of them have an outer securing strip. That's an elastic adhesive strip. And then others have their own device that helps to keep it in place. So you just want to make sure that you know your equipment. And above all, you want to ensure that blood flow is not impaired. We will practice in the lab emptying these catheter bags. And you can see that it's not on the side or the rail. It's below the patient, and that's important. Even when we're turning our patients and bathing our patients, moving our patients, we want to ensure that it stays below the patient. Restorative care. Our patients may need to be taught pelvic floor muscle training. An example of that is going to be Kegel exercises. And one way to teach that to our patients is going to be to tell them that it's that motion that if you're in the bathroom and someone walks in on you, and you stop, that's something that can help you remember on how to train them to do those Kegel exercises. We can also teach our patients with bladder retraining. We will work with them to perform new habits. Habit training, we'll see that with functional incontinence. And then if our patients are in need of self-catheterization, then we are going to provide education. This patient will need to be doing that 4 to 6 times a day, and we will want to be using the teach back method with them or their caregiver to make sure that they were comfortable to take care of this on their own. And that's all that we have for urinary elimination. We will have another video about bowel elimination that will be uploaded soon. Thank you.